Good morning and good afternoon, everyone. It's nice to see those of our audience in New York City and those in Chicago, and welcome to our web participants. My name is Jean Peterzak, and I direct the Abandoned Infant Assistance Resource Center at UC Berkeley. We'd like to welcome everyone to this webinar, both those in our audience and those on the web. This is called HIV, Families and Permanency Planning, Addressing New Realities. I would like to acknowledge the Children's Bureau first and foremost. The Children's Bureau provides support and underwriting to the presenters and the organizations that they represent, and also to the AIA Resource Center. I wanted to also introduce our hubs. So I'd like to greet our speakers and just basically give you names and titles, because you can find your bios in your packets on the on-site audiences or on the web with more extensive introductions to them. So briefly, I'd like to introduce the Chicago group. Linda Kuhn is sitting on the end in Chicago. She's the director of the Family and Children's AIDS Network. Linda, you want to wave? There you are. Okay. Sitting next to her, Wendy Courts is a peer counselor with the Family and Children's AIDS Network. Wendy, you want to wave? There you go. All right. And then next to her is Bryn Polton. And Bryn has been a social worker with the Family Options Project, which is part of the Family and Children AIDS Network for 10 years now. Hi, Bryn. All righty then. It's our Chicago group of presenters. Welcome. I'd also like to introduce our New York presenters. First of all, I'll introduce Adam. Adam Helper is the Director of Legal Services at the Family Center. Hi, Adam. There we go. Okay. And then finally, I'd like to introduce Danielle Jatlow. Danielle has been a social worker at the Family Center, and she's been working on permanency planning issues with families as well. Danielle, hello. That's great. Okay, well, it's wonderful to have everybody on board. I'd like to just start out this very briefly by giving you an overview of a historical perspective that many of you in the field undoubtedly already know about. We're in their sole care, and we're at great risk of being orphaned as a result of higher maternal mortality rates at the time. AIDS was perhaps the first leading cause of death at that time, and then briefer life expectancy rates back then. In addition, there was an enormous stigma that surrounded the issue of HIV and AIDS, and that contributed to a lack of alternative placements for families and children who are affected by this issue. As a result of that research and writing in the field, the federal response became very important. The Children's Bureau with the Department of Health and Human Services, as a result of this, funded direct service projects under the Abandoned Infant Assistance Act that were social work and legal responses to families who are affected by HIV/AIDS and interested in making voluntary permanency plans. The Children's Bureau also asked our National Resource Center to be a conduit, if you will, to develop information and resources on this particular topic. So one of the things that we did was to convene a group of very knowledgeable experts, both social workers and attorneys, to come together and discuss the key issues involved in the field of permanency planning for families that were affected by AIDS at the time. I wanted to mention that this publication, this monograph, resulted in the work of that particular group. This is something that if you go to our resource center at aia.berkeley.edu can be downloaded in its entirety. In addition to that, If you were interested, you could definitely contact the Resource Center at aiarc@berkeley.edu and request a copy of this. A subset of this larger group really needs to be given special credit. Linda Kuhn and others did a great deal of work in order to pull together this monograph and continue to this day to do training at national conferences on this particular issue. These programs, the Family and Children AIDS Network and the Family Center, really are at the forefront of this work and have been, and we owe them a debt of gratitude for this. They've been involved in public education and family advocacy on the issue for a long time and continue to do so. So we're taking a look at the past at this particular point, but now it's important, I think, to fast forward a little bit to the current time. Life isn't static, obviously. Nothing ever stays the same. Not science, not relationships, not lives, not circumstances. As we fast forward to today, we acknowledge that we've made really good headway in the fight against HIV and AIDS, although that headway is not necessarily equal. So there still remain issues. Rapid testing does permit earlier diagnosis and treatment. Medical advances have extended the lives of people with HIV. Which have ultimately helped to keep families intact. I think that at this particular point in time, it's important to turn this discussion over to the real experts in the field. So let me share, before I turn this over, let me share with you how the format for the webinar is actually going to work. We've broken this webinar down into basically 3 segments. So we're going to hear from the Family and Children's AIDS Network first. After their presentation, which basically lasts 35 minutes, we'll have a 5-minute Q&A period. I definitely invite people in the audience to not be shy to ask your questions. I also invite those of you on the web to ask your questions by emailing aiarc@berkeley.edu. We have someone standing by who's going to be handing me those questions, and I will be announcing those questions. So 5 minutes for each one of these segments will be devoted to Q&A. After the Chicago site is done, we'll then turn to New York. And Adam and Danielle will be presenting there, followed by a 5-minute Q&A period. At the end of that 40 minutes, we'll basically be segueing then to our final question and answer period, where we take a retrospective and prospective look at permanency planning. I'll be addressing the presenters with questions. They'll be answering them. And we'll again be opening it both to our webinar audience and our on-site audience. So I think at this time, I'd like to turn this over. And I'd like to begin with Linda Kuhn. The title of their presentation is From Permanency to Stability, Making Progress for Families. Linda?
Thank you, Jean. Can you all hear me all right? Thanks. I'm Linda Kuhn. I'm the director of FCAN. It's the Families and Children's AIDS Network. We call it FCAN here. It's been around since about 1985. We started as a group of social workers and healthcare providers and attorneys who were working with families that were HIV affected. And at that time, back in the mid-'80s, there was a greater need to help families do planning for their children on an emergency basis than there might be today, although we still experience that to some extent. FCAN started as an organization that helped to reduce gaps in services. Really, there wasn't really good programming for families at that time, and some would argue that we still need better programming today. I'd be among those. FCAN started as a sort of a think tank for folks who were identifying problems that families had that were unmet. So we started programs such as emergency foster care or adoption programs, a family camp program, or a retreat program for HIV-affected families. And then we started looking at the need for helping families with permanency options. And at that time, it really wasn't called permanency. It was like, it was more like someone needs to plan for their kids so that they can have a secure legal future, that there might be a guardianship in place for the child, or someone who can be a backup caregiver who has court approval, so there's never any question as to what will happen with the child. I can tell you a little bit about one of the first cases that we worked with that led to our standby guardianship legislation. I'm actually one of the co-authors of that law here in Illinois. We were working with a mom who had a daughter who was about 7 years old. Mom was very ill. She wanted to make a plan for her child in case something happened to her. The child's father had not established legal paternity, hadn't supported the child, hadn't really visited or really helped to nurture the child in almost any way. But she was afraid that he would come back and then want to do something, want to really take custody of that child. And she had, her preference was for her sister, the child's aunt, to take the child. She was spending weekends with the child's aunt. The aunt was also helping take the child to school, to medical appointments. Mom's health was deteriorating. The AIDS Legal Council of Chicago, which partners with us in our program, filed a petition for what we called standby guardianship at that time. And there was really nothing recognized as standby guardianship in those days. But our argument was, and I was volunteering with the council at that time, our argument was that the court should have the authority to fashion any sort of remedy that would really help families in these situations. Well, the court said, you know, there's nothing in the statute that says I can do this. I could make the aunt the guardian right now, and then the aunt would, then the child would have to move in with the aunt. The aunt would have to take care and custody of this child. But I can't do something called a standby guardianship. I can't make somebody a guardian in the future. That person would have to be a guardian right now. And that was the state of the law at that time. So we worked for about a year to get a standby guardianship law passed. The mom's petition had been denied. The case was appealed back up to the appellate court. And the appellate court really just sat on the case. They just really waited until the legislature acted to do something. So after we did get a law passed, after lots of negotiation, as you can imagine, we dealt with a lot of property lawyers on this issue because property is what guardianship stems from in our laws. So we had folks that really didn't want changes made. They really wanted to see things sort of remain the same, and this whole standby notion was really kind of against the grain at that time. So we worked to but we did successfully eventually get the law passed after about a year working at it. And then the appellate court said, oh, well, you know, now you can send that case back down to the lower court, and there is a law, and then the lower court can look at this now. But unfortunately, by that time, this mom had died, so she did not see her plan go into place. She died not knowing for sure what would happen with her daughter. She knew there were a lot of folks working supportively with her situation, but that's the best she knew in terms of a really good legal outcome for her. So her plan did go into place, but she didn't have that knowledge, and so she died without that peace of mind, and also the aunt was sort of left in limbo during this whole period of time until she was officially appointed guardian. So that was the case that really led to us starting work in this area, but there were many, many more cases like this. We've worked on a variety of pieces of legislation through FCAN and through the Family Options Program, including what we have a short-term guardianship here, which allows a parent to appoint a person for what used to be 60 days, now 1 year, to be the short-term guardian of their child. We also have our nation's first standby adoption law. I'll talk about these a little bit more in my presentation. But we've been really active in trying to fashion remedies for families based on actual problems of cases that we work with. FCAN, we started the Family Options Project through what's called an AIA grant, the Abandoned Infants Assistance Initiative. And that's through the Children's Bureau. The AIA Resource Center is sponsoring this webinar. So this is part of a national effort that Jean was describing earlier to help promote these policies and help states also that don't have laws like this either states that have laws improve what they have, or that don't have laws actually establish their own statutes as well. So we started the Family Options Project in 1996, so it's been going for about 12 years now. It's been a partnership with Child Welfare, with FCAN, with the AIDS Legal Counsel, and with individual social workers and, of course, clients that are also, some of whom have become peer mentors, and we'll hear more from them later in our presentation also. So we've gone from sort of looking at permanency as an emergency situation for families, and it still is for many families, but also looking at family stability, seeing that families really need to experience more stable lives in order to even look at what's going on with their children and their futures. Some of the things that we do through FCAM, I'm a lawyer and I'm the director, my piece here will focus on what we do in terms of legal services. We work on the future care and custody planning with families, and we do mostly standby guardianship, some adoption and standby adoption work, lots of wills, powers of attorney for health care to support families that are not necessarily what you would look at as a court-ordered permanency plan, but things that can help families stabilize, both powers of attorney for health care and for property. We also help with assessing benefits and accessing those, so Social Security hearings, for example, other sorts of supports that help families, even advocacy, just advocating with your local DHS office to see what's your option, or with the Department on Aging if you're a grandparent raising grandchildren, and we've been so successful at doing that and appreciate their help so much. So we've really worked on a number of options for families. Most families that we work with really start out with a process where they actually start either with a social worker or with a lawyer. Most families actually have both services. And in your handouts, I'm going to refer you to, there's an overview of the Family Options Program that describes the social work and legal services. I'm not going to walk through that all the way with you, but just so you know, we do also provide aftercare for families, so that once the need for a guardian or a standby guardian or standby adoptive parent to step in happens, we can help with those situations, also help those caregivers do backup planning for children in their care. And also support grandparents raising grandchildren. We have a growing number of clients in our program that are grandparents now, that are raising grandchildren that were orphaned by HIV. We're trying to also look at tailoring more of our services to folks in those situations, because they provide such valuable service and need that support. Haven't really received it in other settings, and of course the HIV piece is very important. We also try to link families with other services we have. We have family retreats for HIV-affected families twice a year, and we started retreats for HIV-positive teens and HIV-affected teens, who are also sorts of growing populations within the system that we're working in. So we're very pleased and proud to be working, providing both the legal and social work services and other supportive services through our program. One of the first clients that I worked with was Wendy Kortz in our program, and she is a client of FCAN, but she's also a peer mentor now, and has mentored a number of families through this process. And so I'd like to turn this over to Wendy now, and she can talk a little bit maybe about how things went with her case. I know I represented Wendy through her case, and we went through a couple of configurations, but I think she tells it best, so I'd like to turn this over to her.
Hello, everyone. I guess this is different from when I normally talk. I have people looking at me. I would first like to say that in starting out in this, I didn't want to do it. It was just a lot of different issues, like I had found out that I was HIV positive. So the first thing I didn't want anybody to do was come telling me how to do any type of permanency planning for my children. I had not even begun to deal with the issue that I was positive. Then I had a lot of other issues going on. It came out of background of incest, and I wanted to keep all of that a secret. And then I had my faith that I believed in, where I wanted my children raised strictly there. And I became ill, but it wasn't an illness. What I like about the permanency planning is when I became ill, it had nothing to do with the fact of me being HIV positive. So in that, I still nearly died, and I met one of the social workers, and I played a little game with her for a minute, and I was like, just brushed her off, and then they sent me another one, which I was very insulted by, because I felt that she was young, she was Caucasian, and she couldn't tell me anything. And she came out and we talked. We had a nice little talk. But I was really insulted because I felt like she couldn't tell me anything. She hadn't lived my life. She hadn't been through my pain. And she was not positive. So I told her to come back, but I didn't let her in, and she would leave notes. It's okay to say no. And it got to the point where I was like, this lady is crazy. I won't let her in. I don't answer any of her messages that she leaves. And then finally I let her in. And today I'm glad that I finally let her in. And we began to do this permanency planning. Well, I had not met Linda yet. So me and the social worker, we got very close. And I found out, like coming up in our background, in our raising, we're told all these different things. And I had my experiences with DCFS and drugs and alcohol. So I didn't want to trust the social worker, but as time went on, it came out to be okay. Then I met Linda. And I was insulted again. She came to my home and she had these little white pearl earrings, and she had on her little suit, and I was like, I dare her. Who are you? And she told me who she was, and we went from there. And then it got kind of, like when a person, we automatically feel like my mother's gonna take my children, or my sisters, or my brothers. But I had in my mind who these people were that were gonna take my children. Well, the first people that I had chosen, she was just asked a simple question and she lied. So I figured if she told that simple of a lie, and I wasn't here, what other lies would she tell? So I didn't want to leave my daughter there. So then the next people I chose, they were part of my congregation, and but the lady, she had just lost a son, also to HIV/AIDS. So she was like really just doing something. It just turned out to be real messy, and we ended up not going that way. And all the time I wanted it to be my son, but I had never stated it to anyone. And we fought and we tussled and we went back and forth. But in the process of this, I had a lot of issues that had to be worked out just for me, also to be comfortable. I told my daughter at a very young age, out of anger, she was a little girl that couldn't understand. And I just walked and I told her one day, I said, I got HIV and I'm dying, and I got to find somewhere for you to go. And then I just started sending her to these people that she really didn't know anything about, which towards the end, when everything got towards the end, she ended up being the one really hurt, because she always wanted a father. So here's this mother and this father figure, and she doesn't have it anymore because it didn't work out. We got right down to the day before court, and they said no. I thought I was going to die. But it all worked out that my son ended up having her. But even after we did that, we did permanency. Now in my family, between my son and my daughter and I, we have a stability because she still needed the social worker. She needed her own help from where things had just been dropped on her and done to her that she really couldn't handle, and I didn't see it like that. Then I still had my own little issue that I had to work out. My son had been molested, and it was just a lot going on at that time. So in the process, even though I did the permanency planning, it still had other work that needed to be done. So when they come and they say permanency planning, what are you talking about? What is it that you're really asking of me? What do you want me to do? And if you don't have someone with the patience to understand and walk through it with you, you just got another mess, this big old mess that's on your hands. And like I say, it was permanency, but it was not stability, and I don't think that's what anyone understands. And then I had my problems with my meds. They have the meds and we're living longer, but I have a problem with my meds. I wasn't taking my meds right. So a lot of us still pass because we're not taking our meds right. Why? I got ill due to mine when I first started, so there was this fear. We're living longer, we're looking better, our lives are more prosperous, but where this one thing is working, something else is going wrong. So all of that has to be looked at and worked out, and and I watched someone doing my mentoring, and it really kind of messed me up because they wouldn't take their meds. No matter what anybody said, they wouldn't take them. So we can do a permanency plan, we can do all of that, but it's still a lot of other work that has to be done, and there's still a lot of dirt that has to be dug up before you can do it. Yeah, the medications are helping us to live longer, but we get lipodystrophy. Our livers deteriorate, our kidneys deteriorate. And I'm not saying that to make anyone feel bad or anything like that. I'm just saying there's a lot more to be done. We're living longer, but it's still a lot of other things in the back of that. And that's it.
Hi, I'm actually that social worker that Wendy was talking about. So I will say that the things that I have learned from Wendy over the years, and about I think 10 years I've known her now, are that I need to be persistent with the families I work with. I really need to get out there more, meet them where they're at, and also recognize the readiness to plan. But I think it is really important to be persistent and to be open and respectful of where they are. I think that you get a better response from families when that happens. But overall, a lot of the services that I provided Wendy and her family range from counseling regarding her past history, parenting support. Also, she's been a big participant in our camps and retreats that we have. Referrals to programs outside of our agency, such as a program that Wendy has gotten a lot out of called Making Positive Changes, and it's a parenting support group for families with HIV. Counseling for her daughter. When that second plan fell through, her daughter was really hurt about it because she had grown attached to this family, and when they pulled out in the end, it was a hurtful thing for her. So around that time when that happened, I think she was probably 10, we did a lot of counseling about her feelings with that. Also, we've done groups at our agency, and one of the groups that her daughter has participated in with us was a teen grief group, because Clara, her daughter has already lost her father. So there's always been issues around that. So that was one thing that she wanted to process more of. Also, we provided obviously lots of supportive legal services for Wendy and her family around, not only around planning, but around benefits, housing, And even just recently, we helped her, some of her hours were reduced for like homemaker services, and she appealed that, and we were able to support her legally in that appeal to help her with that. But the other thing is, I talked to her daughter about how it was for her to know that her mom had planned for her. And some of the things that she told me last night were that it felt good to know that there was going to be somebody to care for her, but in another sense, it was also kind of like, nobody else can take care of me like my mom can. So while it was maybe a little reassuring, there was this feeling from her that there just was nobody else really, and she didn't really know how well it was going to work out. But she, it was nice to know that it had been done. She did feel like it brought her and her brother closer together to know that he was going to be the one that would have cared for her. It has helped them establish a stronger bond. She also mentioned, her daughter mentioned, that she thought it is important to include children and teens especially in the planning process, to really, for parents and for social workers and attorneys to really talk to the children about where they were thinking that they may have who the caregiver may be for them if something would happen to a parent, because they have opinions as well, and since they're the ones that are going to really deal with the ramifications, it's important to make sure that they're comfortable with what the plan is. And the best thing about this is that Wendy's daughter is now just turned 18, and so legally, we don't need the plan, but I talked to Wendy about this a little bit too, about if she felt like it was still important for her to do that plan, even though her daughter has reached the age of 18. And her opinion was that it was still very important, and one of the reasons is that this person has now always been in her daughter's life and is always there to give her support and can continue to give her support even past the age of 18. So if something were to happen to Wendy in the future, she knows that there's this person that her daughter can turn to no matter what for assistance. So another thing that Wendy has done for us is she's been a peer mentor and an outreach worker for our program, and in that capacity she's worked as a mentor. She speaks for our agency. She is great about providing her own life story and talking at a variety of conferences about how she's made so many changes in her life. Her daughter has also spoken at conferences for us, and she's also helped to recruit people who are considering planning. And one other thing she did, she's also worked with a lot of families, and she briefly mentioned a family that we both have worked with more recently. It's a family that we worked with for a long time. It was a mom who I'll call Sally, who really struggled with planning, went back and forth. We probably worked with her for over 5 years and went back and forth on who she was going to choose to plan, changed her mind just about every year it seemed, and would never really go through with the plan. So, increasingly within the last year, I'd say she started to become pretty ill. She was in and out of the hospital with a variety of illnesses. And she had 3 daughters. I'm sorry, I didn't say that. She had 3 daughters that she was planning for, and they are ages 7, 9, and 12. And then it got to a point this past year when she was really sick. Sally was in the hospital all the time. In January, she was on a ventilator on life support. So during this whole process, Wendy was incredibly helpful to the family and offered so much support to Sally. It was, we couldn't have done it without the support that Wendy lended us and to Sally too. So the thing that I did notice, though, I think as the peer support, you have to also, for Wendy, I felt like I really needed to make sure that she was okay during the process, because there was a lot of stuff I think she was picturing herself in Sally's situation, and she needed to be able to take a step back. So, throughout this process, it was very important to give Wendy the support that she needed. Then in February of this year, I had just gone on maternity leave, so it was very difficult for me about 2 weeks after Sally passed away. So again, it was just really, I was so thankful that Wendy was there because she provided so much support to the family and to Sally's daughters that I don't think that they could have made it completely as well as they have without the support of our Wendy, our mentor. So, you know, and she continues to stay in that role for us. But okay, on time. I guess the other thing I just wanted to go over briefly, because I think I don't have a lot of time, are just some of the challenges that we continue to face with planning. And some of those are, Wendy briefly talked about it, medication adherence. While the medications are great and have really extended the lives of many of our of people infected with HIV, they're also very difficult to take. And some people just have a very difficult time with a lot of the side effects, and they decide that they aren't going to take them, which is something that happened in Sally's case. The stigma of HIV still exists in many communities, and it's hard to know how to reverse that stigma. But I think one of the things we can do is talk about it. And then lastly, the challenge of disclosure. It's still, because of the stigma, it still continues to be a really difficult issue for families and for people infected. And one of the things that we've done to try to work on that is to, we have someone who specializes in working with families on disclosure, and she will go out to families who, no matter in what capacity they're considering disclosing, she'll go out and do some individual work with them as well. And so far, it's just started. It has seemed to help out a lot. But I'll just end by saying I think some of the continued benefits of the permanency planning are, it still does create some family stability. It gives kids some idea of where they're going to be going. It also gives the potential caregiver ahead of time. It gives them time to build a relationship with the child, and it gives them time to prepare, to know that this is something that they might take on at some point. Whereas if it happens, quickly at the end of life, that preparation is not there. It helps, Wendy has always said that it gave her a lot of peace of mind to know that this was something that she did not have to worry about anymore. Parents can provide, it gives parents a chance to really say who they want. It's their way of advocating for their children. And then it's also, like I said, planning is important no matter your health. It's important for people who aren't infected with HIV. It's something that all parents should do. But I think I'll end there. So if there are questions. Oh, I'm sorry. Sure. Oh, to Jean. Sorry.
I'm going to do the same thing. I'm going to take this opportunity. Hello. I'm going to take this opportunity to ask both sites, audiences from both sites, if there are questions. So let me go first to Chicago and ask whether or not there are questions in Chicago, and perhaps one of the presenters could repeat the question in the event that the mic is not good enough there. There we go. Hello.
Hello. Touch this, but apparently you have to touch it. Is that better?
That's much better.
Okay. I have a statement and a question. Everyone has become aware that HIV is rising in the African American community especially, and more people are infected. My question is for Wendy. When you became involved with this group of individuals, was your anger about the fact that you were infected?
Okay, can Chicago, could you please repeat that question? We're having a little bit of technical difficulties with the mic.
All right. My question was whether or not Wendy was angry because she was infected, or was she angry with the group because she felt as though they could not relate to the Black experience?
Did you hear us, Jane?
Yes. We were able to hear it, Wendy.
I was more angry because they could not relate to the black experience.
I'm so glad you gave an honest answer on that. Because that's an important piece of it. It was not her anger about being infected, but how when she said the little curls, that's what made me think. When Linda came in. About being tested, particularly when they want to come.
The problem is that people asking questions are too far from the microphone, so he's trying to turn.
Crosses, color lines. This is a people
So
issue.
either
I'd like to can I have them put a chair right there and they can come sit?
Of being able to share information with you, the information is needed. So is there something that you would suggest
Calm.
to individuals who are working cross-culturally in trying to break down that barrier with a young person?
Did you hear that, Jane?
You know, it's going in and out, and so what I've suggested, perhaps, I'm being told that the speaker is too far from the microphone, so if we can pull a chair up, when people come to the microphone in Chicago, perhaps you can sit and ask your question.
Okay.
Not the speaker, though.
You wanted the person asking the question, Jane?
Yes, Linda, if you could just pull that chair over to where the microphone is for the people asking the question. She needs to be close to the microphone at the table. There we go.
My question is this: would Wendy like to be able to share with us some things that might be helpful when you're cross-culturally, cross-racially working with individuals who are HIV infected? That might be helpful in terms of breaking down the barriers.
You ready for me to answer, Jane?
Yep. Go ahead, Wendy.
Oh. Well, like Brian said, really like meeting us where we're at. A lot of times they come in and they believe that they have assessed a case and they haven't even scratched the surface. So really it's just meeting me where I'm at. If I appear to be angry at that time, you know, hear out why I'm angry. And the first thing, don't assume it's because I'm HIV positive. Because like I say, that's just like scratching the surface, because it's really a whole lot more there. Like you said about the pearls, I'm laughing because I stopped. But when I told Linda about it, she said, oh, that was not my intention. I knew it was not her intention. But it was just the pearls. I was offended. Is that okay?
But I really kind of wanted you to just give us just a little bit more about what was it ultimately that Brand did that was able to diminish the barrier that you built up immediately upon seeing her that allowed her to really get to you?
I was able to actually tell her about my life, my past, and she didn't judge it. She didn't judge it at all. She said, so that was then, this is now, so what do you want to do now? So in the end results, I ended up, like I tell people, I had a cell phone, and what she would call it, it would say the most capable social worker. And then like my girlfriends, before anybody met her, you know, I hope no one's offended anywhere that's listening to this. I would say, oh, y'all gotta meet my little black-white girlfriend. Because she just accepted me for who I was.
So being non-judgmental was just the
She
real key to this.
she wasn't judgmental about anything.
All right. I would like to actually take this over to New York, the New York site. Is there anyone from that audience that has a question in New York?
I don't think so, Gene.
Alrighty. Okay. Well, then I think we're going to go forward a little bit and switch gears here and go on to New York for your presentation. That's all right now. So again, this is Adam and Danielle, and this segment is going to be addressing working with HIV-positive youth, young adults, and their families in an interdisciplinary approach. So take it away.
Gene, thank you. And I also want to thank Linda, Bryn, and Wendy. That was a wonderful presentation. I'd like to start ours out with an exercise. And I'd just like to be indulged for a few seconds, like everyone, everywhere, to close their eyes for just a second. Indulge me if you will. I'd like everyone to think about themselves as a teenager. So I'm going to close my eyes here. Think about yourself as a teenager. For me, it was probably a while ago. It depends on where you are, but I'm sure we can all get back to that point. I'm going to say a couple of characteristics, and then we're going to come back to them. So, yourself as a teenager. It's pretty much static between the ages of 12 and 19, right? You had no issues with your body, no major psychological issues, no emotional issues. It's all pretty steady. When you had a behavioral issue or you had to be disciplined in some way, you talked with your parents, the infinite spiritual guides, and in a 15-minute conversation, the issue was resolved. Behavioral transformation took place. It was all pretty simple. Teenage, the adolescent years for you, they were pretty smooth ride. How am I doing so far? Does that describe most people's teenage years, or does it not?
Yes.
It probably doesn't for most of us. It certainly didn't for me. And I'd just like to add to that, just taking it just one small step farther, is that in imagining yourself as a teenager, going through all of the issues, completely antithetical to everything that I just mentioned, that you're now also HIV positive on top of it. And you're dealing with all of the issues, all of the changes, all of the adjustments, all of the growth that is usually associated with being an adolescent, and now you have a chronic illness which brings with it a very unique set of challenges and circumstances. This is the population that we want to focus on specifically today, and that we're going to be touching on through a couple of different venues. So Danielle, would you like to talk a little bit about the Family Center?
Yes. So the Family Center was born from a desire to help children who are experiencing parental loss. We serve individuals and families affected by all kinds of illnesses, but we primarily work with families affected by HIV and AIDS. The Family Center provides a wide range of services: social, legal, groups, medical case management, and research. These services are provided to all kinds of configurations of families. We serve young people, older caregivers, younger caregivers, and biological parents. Our services are offered in Spanish and English without regard to income eligibility or immigration status. Our services are free, offered in the home if necessary, and we serve families in all 5 boroughs. 95% of the families we serve are below the poverty level, and most of the parents we serve are African American or Latina single mothers with 2 to 3 children. The caregiver is usually the maternal grandmother or the aunt.
We're coming into a new generation of HIV-affected consumers. What we're really seeing now are the children who are born of HIV-affected parents, the perinatally infected, who were born either just prior to or at the moment when ARV drug therapy became effective. Also of note in this presentation is that, at least here at the Family Center and I think elsewhere, we are seeing behaviorally infected youth who have been brought up to believe that HIV is a chronic illness and not necessarily a fatal one. Insofar as we're going to be focusing on the perinatally infected youth here, both in our discussion and through the case examples that we're going to bring out, we also want to say that some of these issues are really applicable. In fact, most of them are really applicable to the behaviorally infected youth with HIV. want to focus on three core concepts here. First, permanency planning with this population is exceptionally complex in the best of circumstances. And we're going to talk a little bit about issue spotting and process with that. Second, a multidisciplinary approach, meeting the client, and I like how just a moment ago, one of my co-presenters said that meeting the client where they're at, I think that was you, Bren, is the most, going to be the approach through best practices that is going to most likely achieve a good, successful, and sustainable permanency plan. Part three is that, other than to say it like this, the earlier the intervention, the more likely it is that the family and the permanency plan are going to remain stable, and that the earlier one gets services and provides services to the family across many different access points, the more likely it is that people are going to be healthy, well taken care of, and that a permanency plan is actually going to be effective and provide for the children. Danielle, you recently had a case that brought out some of these points. Did you know?
Yes, and I'm going to talk about that case now. Actually, the case I'm about to talk about is about a perinatally infected youth in early adolescence and her caregiver. And then later we're going to talk a little bit more about a young adult, a 19-year-old who is perinatally infected who has a young child. So those are going to be our two main cases today. So I'll start in with the Rowe family and just mention that all names have been changed for confidentiality. The Rowe family is an African-American family. They reside in New York City. Ms. Rowe, an HIV-positive mother of two, came to the family center seeking permanency planning services and support around disclosure issues. At the time, Ms. Rowe had an 8-year-old daughter, Ashley, and a 2-year-old daughter named Jenny. The fathers of Ashley and Jenny were no longer in the picture. Jenny was born HIV positive. Early on in Jenny's life, she lived with a foster care mother, we'll call her Mary, and Ashley lived with Mrs. V, a close family friend, while Jenny was in foster care, so that Mrs. Rowe could receive supportive substance abuse counseling. By 2000, both girls were back with their mother successfully. Ms. Rowe had also completed her permanency plan and had designated Ms. V as a standby guardian for both children. In 2007, Mrs. V, who was the proposed standby guardian, she was now 68. She contacted the family center to state that Ms. Rowe was in the end stages of life and living on a respirator. Her health declined very quickly. Nobody expected it. Ms. V was calling the family center because she was feeling very overwhelmed by making health decisions for Mrs. Rowe, and she was trying to navigate various systems for the children. At the time, Mrs. V was caring for the two children while they were still residing in their mother's apartment, which is in a different borough than where Mrs. V and her husband live. In May of 2007, Ms. Rowe passed. That same month, Adam started working with Mrs. V to provide assistance with legal matters. The initial plan was for Mrs. Rowe's children, now ages 18 and 12, to remain living together in their mother's apartment. And Mrs. V would just monitor them from her house, which was in a different borough. Without warning, just after Mrs. Rowe's passing, a competing guardian, Jenny's previous foster care mother, who I mentioned earlier, arrived on the scene, took Jenny out of school, and told her she was HIV positive. Okay, so this was an inadvertent disclosure. Jenny had not known before her mother passed that she was positive. So this was quite a surprise. Then the previous foster care mother filed an emergency petition for custody. There were 2 court appearances and papers were submitted. The decision was made for Jenny and Ashley to remain under the control of Mrs. V. As of July of this year, Ashley and Jenny moved in with Mrs. V and Mr. V and their adult child, and I'm currently providing supportive counseling to Jenny around grief and loss over her mother. And I'll talk more about that shortly.
Just to add a few points, Danielle, from the legal perspective, our role here was pretty short, and thankfully so. We filed papers. This is someone who had really done everything right. Miss Rowe, the mother here who is HIV positive and passed away, had really done her job here. The court had pre-approved the guardian to take over the children, and then several years later, there was a surprise anyway. also, in addition to working on the family law stuff, we were able to work with her on public benefits matters, which had really to do with accessing benefits for the 2 children that were now going to be under Ms. V's care, as well as housing issues. And there were succession issues over Ms. Rowe's apartment that had to be dealt with that had really not been planned for. I think what struck me first about this case was that even as we were doing the legal work, which was maybe a total of 2 or 3 months at most, to be perfectly honest with you, there was a ton of emotional trauma, partially caused by the inadvertent, or rather the unintended disclosure to this child that she actually had HIV. And I found that over time we were really talking about that. And Danielle, would you like to say something about that?
Right, so under the best of circumstances, as Adam mentioned before, working with perinatally infected youth is very complex work. So in addition to the grief and loss work, which is really just the presenting issue, as a social worker, the other issues I'm working on with her are around losing a mother to a highly stigmatized illness, the inadvertent disclosures we mentioned that occurred just after her mother's death, her relationship to her sister, who is not HIV positive. And we find that this is an issue in a lot of families with the perinatally infected. One sibling is positive and one isn't. Getting up to speed on HIV education. Once you learn you have a health issue, what do you need to learn? With HIV, you need to learn about, medication adherence, what's the CD4 count, what is a viral load, understanding lab results, kind of what your doctor's appointments are going to look like, transmission prevention. We also had to deal with, and are still dealing with, Jenny's own thoughts and feelings about disclosure to friends and family and other people, which also includes handling stigma. The transition, of course, to living with not only a new caregiver, but a grandparent caregiver, changing homes, living in a new borough, changing schools, being uprooted from her support and other community resources. And I have to say, this case is not the exception to a majority of the cases that we work on here at the Family Center. From Jenny's perspective, she was just a normal 12-year-old girl, maybe didn't clean her room once in a while, got in trouble for that, but all of a sudden her world was turned around. It turned into, she's a 12-year-old girl whose mom got sick, passed away very quickly. She was told that both she and her mom had a highly stigmatized illness. She had to move in with a new caregiver. There are new rules under that home. All of these things are really can be very highly charged for a young person. Keeping in mind what Adam led us through this exercise, what it was like when we were all 12. So along with all the normal adolescent development issues, you have all of these things on top of that. So I believe some of the complexity of the work that we're working on now could have been avoided if more work was done at the front end of planning. That means working closely with biological parents and caregivers together to discuss the intricate details of the concrete and emotional issues that children and youth and young adults face in the event that something happens to their parent. While a plan had been made, complicating factors made it all the more difficult of a situation for Jenny.
All of those complicating factors got visited upon Miss V times 1,000. Again, here was someone who did everything right. Here was someone who was in the children's lives, and she had kind of been a continuing presence in their lives right up until the passing of their mother from HIV. And she was well familiar with a lot of these issues. When the storm happened, it really, I think, even took her by surprise to hear her tell it to me, although I sense that she probably talked more about that to Danielle. She was astonished at how unequipped she felt in the moment. What's notable here is that I think a little more work could have been done, certainly on our part, I think, in terms of the public benefits and the housing issues. Something notable about Ms. V is that as a caregiver, and we certainly see a number of people like her, she was a person who had been in and of the world. She had had a career. In her retirement, I think she was approximately 68 when we're discussing these facts. She had started her own catering business. She was married. She had a house in one of the boroughs. She had really been adept at negotiating all kinds of life situations and had a wealth of experience behind her. It all got tested when she approached the public benefit system for the Medicaid, among other things, which was sorely needed and needed to be dispensed with quickly because of Jenny's needs. Also, she got a real education in the form of public housing. And trying to figure out what to do with Miss Rowe's apartment. It had been her intention that the children were going to stay there. And she would kind of monitor the situation as a guardian from afar. Well, that got blown up when we ran into court, filed an order to show cause against this former foster care mother who apparently had her own motivations for being involved in this situation. And the judge was kind of fuzzy with whether or not an 18-year-old and a much younger child should be living together in an apartment by themselves. Ms. V did everything correctly. She adjusted her course of action, brought the children home with her. And what's remarkable is that even with an extraordinary amount of presence of mind, she was really able to still feel this incredible, I don't know how to say it, the storm of being overwhelmed. And what's notable is that over our experience with her in the legal department, I found that our conversations really started taking on more of an emotional quality, more of a venting quality, and it really started turning into therapy. I'm not too sure if it was therapy for her or me, but it was definitely started to be therapy, and I think that the multidisciplinary approach was really what got her through that situation.
Yes, and actually taking a multidisciplinary approach is essential. It's something we do here at the Family Center. Families with HIV are often dealing with other issues, such as poverty, substance abuse, inadequate access to resources, educational systems, quality health care, employment opportunities. To this end, they also have a lot of issues with entitlements and housing. To this end, when a family is facing eviction, or let's say they don't have milk or diapers for their children, therapeutic work is not going to be a priority, nor should it be. And at the Family Center, working on the multidisciplinary team really allows us to address all of these issues, the permanency planning, the housing, the entitlements, and the therapeutic issues. And they're very interconnected. We provide varying levels of legal, social, and other services depending on where, as Adam mentioned, depending where the family is at. And if I have to say about this case with Jenny, if Adam had not completed the necessary legal work before I started working with Jenny and her caregiver, I'm sure I would not have been able to engage them in supportive counseling. I would have been doing crisis intervention. And we do crisis intervention as well. But for basically, the other issue comes into play is managing health. We find that health often declines when legal or other stressful issues are on a family's plate. So to be sure we're reaching our goal of helping families become more stabilized, we need to offer legal, social, and medical case management services.
Interconnected. That's really kind of the word to describe this. It's interesting because Danielle, you note that without the housing, without the public benefits, kind of more practical needs on some level, that you couldn't have really done the mental health stuff. It's interesting because I don't really think any of that stuff would have been effective at all had not the mental health component of it been addressed. The prevailing issue here, I think, in a lot of ways, were what to do now amidst grief, amidst medical adherence issues, amidst disclosure issues, and how to proceed from there. I think that without the mental health services, without really strong supportive services that certainly has been mentioned a number of times today, that these children really were in jeopardy of going back to foster care. I certainly hope that they wouldn't have gone back to this competing guardian, this former foster care mother, but I think it's entirely possible. Certainly in the way that Miss V related her conversations to me. At moments, it sounded like she was as well prepared as she was right on the cusp of giving up, and to be honest with you, I don't think anyone could have blamed her. I think also the one helpful thing to remember here is really to look at the model of service. I was infinitely assisted here by the fact that I was the only attorney on the case. In another venue, Miss B might have gone to a different agency and she would have had a public benefits attorney, a housing attorney, a family law attorney dealing with the guardianship and this competing guardianship claim. And each one of us would have had a certain piece of the information. What was nice, although at times it was exciting, to coin maybe a poor phrase for it, was that I kind of had all the pieces of the puzzle. I had them all at my disposal. I knew everything that was going on and how everything was interconnected. What was clear, I think, at the end of the day was that it didn't really end with my intervention. And I feel, although the intervention that we provided ended after 2 or 3 months, the guardianship, the public benefits, and the housing, the mental health issues continued long after I walked off the scene. And I'm glad that it just wasn't a straight legal case and a walk-off from that point.
Right. So, which brings us to our third point. The earlier the intervention, the better the outcome. Perhaps the most important work that I do with Jenny, who is 12, is to help her to internalize healthy decision-making. This starts to reinforce future-oriented behavior and thinking. By practicing and repeating the empowering process of weighing tough options, we discuss issues around medication adherence, negotiating family, romantic, and other kinds of relationships. We talk about nurturing social supports, getting involved in community resources. And Jay is now learning the importance of internalizing this process and taking care of herself in the long term. So while most youth in early adolescence are not really future-oriented thinkers, it's still important to make sure that the possibilities for the future are very open to them. I've seen a vast change in Jenny in the past year. She's much more confident about what she wants for her future, and she's much more in control of how to stay healthy and take care of herself. The earlier that HIV-positive youth are able to make healthy decisions for themselves, the less likely they will be to suffer from social isolation and to have other issues like depression or other mental health issues. This will benefit them, and it'll also benefit their children should they decide to have them. Likewise, if interventions do not happen early enough, self-care and healthy decision-making will not be internalized. Youth will then become young adults and then possibly young parents who still may be socially isolated and who might suffer more frequently from depression and other mental health issues.
I think that it goes without saying that as difficult as the situation was, it would have been much more difficult without the early intervention. Again, just to refresh, this was someone, Miss B, who had been designated as the guardian long before Danielle and I started working on the case, a number of years actually. What I think that allowed ultimately, and I think it was very clear, believe it or not, to the court during the hearing, was that she had really had a very long period in which to get to know the children. She had a long period to kind of get into the home, understand their issues, and it really came out very easily through her testimony, which, to be perfectly honest with you, surprised me while she was on the witness stand, but it was authentic. She really did have an opportunity to become their guardian long before the court gave her a piece of paper saying so, and I think the early intervention by Ms. Rowe in our services several years before it actually assisted with that. Something I wish we had done differently is really with reference to that kind of early intervention, which is that she really described to me that she had not had a full education, or at least a modest education, on the myriad public benefits issues, housing issues, kind of the brass knuckles economic issues of what it is to take 2 children, one of whom has quite a number of medical health issues. I think what I might have done differently is I wish I could have given her something like a caregiver's handbook, to kind of let her do some of the work herself. She wanted to take control back of the situation, and at times she said that she was losing control and she wished she could take some type of affirmative step to work on things herself. At which point, of course, I just transferred the call to Danielle. I think that for someone like this caregiver, who was an excellent caregiver of a perinatally infected youth, she really could have done those steps. She could have taken some action without my being there, and it's something I wish we had done a little bit differently for her.
Right. Well, let's actually move forward and think about, Jenny's 12, but we want to kind of move forward what would happen in a few years when she's at childbearing age, and kind of learn more about that. Adam, you had a case like that recently.
I did. Her name, well, let's call her Sandy S. I'll go through the facts very quickly. She had in no way any of the supports or any of the services that Jenny had. She was really the tail end of what happened when nothing was put into place. She's 19 years old, or was 19 years old, HIV positive, had just had a child at 18. Both of her parents had already passed from HIV. She thus had very little by way of parental and or social support. She came to us ostensibly regarding an SSI hearing. She was applying for SSI, or rather she was appealing her SSI, because despite her numerous health problems, she'd already been denied a number of times, and now she was being told she had to appeal the decision, so we were working on that with her. The most shocking thing about the case was really that Sandy displayed, I think, in total, and added a few new ones, every imaginable mental health and social issue that I listed on page 4 of the outline. She was arrested in development. She was socially inappropriate at times during the hearing itself, which was an interesting challenge. She was completely isolated socially. She basically lived with her very young child, dealing with her illness all by herself in a small, publicly subsidized apartment. What ended up happening, and the reason why I bring her up, is that permanency planning effectively didn't take place. When broaching the conversation of what to do about this, or whether or not she wanted to talk about what was going to happen to her young child, given her condition, it was a wall of resistance. It was a complete, utter zero on every level. We tried to bring it up in a couple of different ways. The question was broached here and there, but at the end of the day, she kind of hung up on the phone on us a couple of times, both literally and figuratively. And I think that absent, a good early intervention for her, absent some good services, much earlier in the road, essentially permanency planning didn't happen, and she basically got her winning decision, which was in and of itself a miracle, and she left, and she didn't partake of any more services. Well, we've seen a lot of clients like Sandy recently, somewhere in the age of 18 or 19 years old, young children, perinatally infected, and going through and living with their illness for a very long time. A couple of thoughts about it. One is, and I believe it was said before by Wendy, referenced it, is that permanency planning may not be at the top of the list for our HIV-affected teenagers who are with children, and it's probably worthwhile to really, I love that line, really try and meet them where they're at. And that's what we're trying to do. I think in the past we've had more success with reframing the issue. So when I said permanency planning, or when one of my staff said permanency planning, she instantly understood that to mean death. That was not an effective way to broach the issue with her. And we really would have wanted to try to reframe it as lifetime planning, and that this was an issue that all parents should consider, not just HIV-affected teens who are going through all kinds of other nonsense. I wish we had engaged her with more activities. I don't think, although I'm wonderful, that she really wanted to engage in a lot of activities with the legal staff. To be perfectly honest, I think that she, in answer to the social isolation and in answer to kind of the inappropriate behavior, I think she really could have used being brought in through groups, through other supportive services, through doing things that were not just kind of a business transaction, which is really how I felt as though she was viewing us. The other thing that I think was really important here was that there was a lot of interdisciplinary education that allowed us to even be mildly successful in this case. I had at least a basic 101 understanding of some of the social services issues that she was going through, and that was, believe it or not, infinitely helpful in just getting her to the point of actually publicly talking about her illness at her SSI hearing. And I think that education, we need to take that on as providers and really not just say cross-disciplinary education, but actually do it in our agencies, and I think it's important. I think at the end of the day, what really happened was that, not unlike some of the things we talked about today, we ended up just reacting instead of acting. And I hate being in that position. It certainly is not uncommon in this work, but it would have been so much better if we had been in the position of action, as opposed to fighting and working with this client on our heels. And really, I felt as though the crisis management, although we do it all the time, it's really not how best to serve our clients.
Right, right. So we hope we've given you a snapshot of the kind of work that we do and the important issues that young people with HIV are facing. Certainly it's just a snapshot. While we've learned so much from all the families that we work with, I would say the 3 core points that we want everyone to take home are that, these cases are very complex. Working with young people affected by HIV and their families, it's not simple. There are always surprises that come up. Taking a multidisciplinary approach, both in theory but mostly in practice, is very important. And finally, the earlier the intervention, the better the outcome. So those are our 3 points. We want to thank AIA for inviting us to participate in this conference, and we hope that the audience will feel free to contact us if they have any questions or comments or thoughts.
Thank you. Any questions?
I'm sorry. Thanks so much, Adam and Danielle. It sounds like you're signing off, but you can't go anywhere yet. So at this particular time, I'd like to open it up for questions from both audiences and also the web. But thank you very much. That's great. And I think really groundbreaking, kind of very thought-provoking information for this population who is certainly being impacted by this in a very direct way, but we're still working out the responses to it, if you will. That's the thing that's been so interesting, I think, has been going through this disease. We're constantly on our toes, I believe, in order to respond very effectively and continue to improve upon those responses. So it really does keep us all on our toes. At this particular time, I wondered if we could start with New York and see if there's anyone in the audience in New York that has a question for Adam and Danielle.
Please.
My question is, with the second case that you discussed, Sandy S., would it be fair to say that the way she handled her status was a direct result of the way her parents handled their status, their HIV positive status, and that could have been why it was somewhat more difficult to work with Sandy S. than, say, the case with Jenny and Ms. B, that they were much more open with their status, and the children, except for the younger child, they were aware of what was going on, of how the mother was really taking a proactive approach in planning out her children's future.
I do want to ask, was that question heard?
Yes, it was, Adam.
Thank you, Jane. Yes. I think that, one of the interesting things that we're finding with this population is that there are very few parental supports. Part of that has to do with the fact that the parents have generally already passed away from HIV. She's been left alone to deal with her illness for actually quite some time. And not only that, but she was left alone right at the moment when she probably most needed her parents, which was somewhere in the nature of 11 or 12 years old, right when Jenny lost her mother. So she's had a guardian, and she's kind of had some other people influencing her, but at the end of the day, through a combination of things, not the least of which is that I feel as though she hasn't had that positive, kind of role models, not a lot of positive responses, and a total absence of services, that she's kind of ended up in the place where she is. And I think what ended up happening is that was very hard to reach. She kind of closed us down on a lot of different fronts. She came, she wanted what she wanted, and she left. Regardless, I obviously can't be in the position of kind of, forcing anything on anyone, but I think it was clear to everyone that she could have benefited from a lot more. As a final point, I'll just say the other person who really felt that way was the judge at her SSI hearing, who during her testimony stopped her and said, "Have you ever thought about going into counseling?" Don't know if I'm speaking for everybody else here, but I don't find that moment judges paying attention to that level of empathy to clients' mental health to be very common. And he's kind of put his hand over the microphone and said, "I think you need a lot more help than what Mr. Halper's given you."
If I could comment, I've worked with a number of cases where parents have been around to talk to their kids about their health status, their own status and their child's status. And I would say I'm always careful to kind of assume that the children are going to kind of have the same feelings and thoughts about the health issue as their parents, although they are very much influenced by their parents. So parents do have a wonderful opportunity to talk to them about their health issue and support them during the most crucial moment.
Great, thank you. Any other questions from New York?
I have a question. In the first situation, the new caregivers were 68 years old, and Jenny Wright is only 12. Was there any thought about a successor, if that was necessary, given that often that it's grandparents or older relatives that take care of young children?
Yeah, I mean, we're still thinking about that right now. I think also Jenny's older sister, Ashley, is 19 now. So I think the idea is kind of moving towards, whether Jenny and Ashley can, go back to that original plan, which was living together and having Ashley take care of her. But we are currently talking about successor planning with the family right now.
We generally discuss those issues with our grandparent caregivers, and for a whole host of reasons, which is probably beyond the scope of this presentation. Many of them do engage in planning with us, and some of them don't. It kind of depends on the situation, their health, among other things, and really what are going to be the kind of logical next steps when they pass.
Okay, great, thank you. How about Chicago? Do we have any questions from the speakers or audience in Chicago?
Yeah, I wanted to ask a question to Danielle. You talked a lot about early intervention being key and working with youth. How does disclosure play into that, and particularly if the youth that you're working with is HIV infected but has not been disclosed to?
Yeah, it's really tough. I have a case in mind where it took a really long time to have that disclosure conversation. I work closely with a lot of other providers. So for example, the family that I'm thinking about, both parents were positive, and the daughter, who was 13, was also positive but didn't know her status, but was starting to act out in school, have some behavior issues. And we had a feeling that the disclosure process was going to help some of these issues. And her parents were very reluctant. But I worked with a number of other providers from some of our partner agencies. One was a health clinic in the area, and one was a COBRA case management organization. And we were very persistent with the parents about the disclosure issue, all the while engaging the young person in some of our, as Anna mentioned, activity groups here. We have a lot of programming for youth that is not HIV specific. And so we try and get clients involved in those services. If we find that if we get young people involved in some of those more activity-based if that some of the activity-based programming, they're more likely to engage in counseling or other services, more of our core services later on. So without, of course, breaching confidentiality and her status, kind of getting her involved. So at the point when she needed us most, possibly after she was disclosed to, we could have already formed a positive relationship with her, and she would feel that she had an extra community support to work with.
Great. Thank you. Any other questions from Chicago? We actually have a question from a web participant that is a little bit general, but I'd like to pose it at this time. Jenny from Florida was asking, what is the best way to encourage a legal team member to become involved? Is there a national network of legal consultants for remote areas? Let's presume that Jenny is from a remote area in Florida, especially in regard to different states having different legal systems. So Adam, Linda, are you aware of any national networks of legal consultants that can be accessed? Or at least, it sounds like at least to provide consultation to a local attorney to get involved, perhaps.
Hello, this is Linda.
Mm-hmm.
I can address this a little bit. I do get questions from legal service providers from different parts of the country. I'm certainly willing to give out. I think you're going to be giving out our contact information also.
Yes.
At the end of this. But there's also an HIV legal listserv, and questions like this do come up on that listserv. The listserv primarily does not address the questions on that listserv. Do not primarily involve permanency issues, but they have. And so that's another way to go about it. We also have our National Technical Expert Group through the AIEA Resource Center. And so those of us on that group, I think, can be available for consultation for some questions for attorneys from remote areas. So we frequently at FCAN do consultation statewide. Have a good familiarity with remote areas in Illinois, but I'm certainly willing to also give consultation to folks in other locations.
That's great. Adam, anything to add?
Yeah, I just briefly thank you, Jean. I think that there's always a local bar association somewhere. In New York, there's quite a number of them. And there's a lot of people who want to try and get involved in this work. You may find that like a lot of projects here in New York center around elder law, center around family law, and there are whole teams of people who are really looking around to get the private bar involved in this type of work. We've seen that we do a lot, as Danielle mentioned earlier, that a lot of our work is often conducted in the home. It's a very impactful experience and is one that can be very attractive for people, lawyers who are not used to making a house call. And with the proper training usually given to them by a bar association or some similar type of entity, that there is a lot of ways to get people who normally would not be involved in this work, specifically lawyers, can be brought in, and I think find it very, very rewarding. I don't know if that answers Jenny's question, but just a thought.
Well, as Linda said, with regard to contact information for all of our speakers here, you can find that on the web. It is one of the attachments on the web. And for others, the on-site audiences have that contact information in the folders. So it sounds as though all of the presenters here are more than happy to take questions and to field questions and provide information as they can. And we at the Resource Center are always happy to help too. Please feel free to email us and we'll do what we can also to point people in the right directions. I'd like to segue now to our final segment of this webinar. And it really is a series of Q&A that we have developed and spent some time thinking and discussing as a group. And what this purpose is to really take a retrospective look and a prospective look at permanency planning. And I've asked this particular group to think about some questions, and so I just want to pose it to them, and then we will again open it up for Q&A to our various audiences. So the first question, it's really a statement of sorts. Legal and social work teams have been working with families affected by HIV for the past decade, helping them plan for the children's future care and custody. And this obviously is more pronounced in some areas than others. Some of you have been addressing these issues for many, many years. What aspects of the work have remained constant despite this passage of time? Danielle, I'm going to call upon you first. And there we go with your audio.
Okay, great. So I guess the things that come to mind for me that have been prevalent, remained constant over time is stigma. That has not gone away. The difficulty that family members and people affected by HIV have with disclosure. I think disclosure was mentioned a number of times. Along with that goes discrimination. I think all of these things are tied in together and have been constant. There's also a disproportional incidence of people of color and young people who are affected by HIV and AIDS. So that is something we need to continue to look at. And HIV, though we have made major advances with medication, it's still a very complicated medical issue. It's complicated to manage. It's complicated to get up to speed on education. Things are constantly changing. So I would say that it's still a very complicated health issue despite the advances.
Okay. Linda Kuhn.
Sure. Okay. Really, I've been in this work since the late 80s, and I think the aspects that have remained unchanged during this whole time the work involves assisting people who are terminally or chronically ill. They frequently have poor access to health care. They have a great distrust, as do most people, of the legal system. Frequently have no access to HIV prevention services. They're poor, largely minority. They face stigma and discrimination, not only HIV discrimination, but also racism. And that continues. One other aspect that I find very challenging is that although we think that most folks understand HIV in this country now and know something about it and know something about prevention and transmission, they largely don't. I'll talk in a little bit later about some of the work we've been doing around HIV and discrimination in schools. But the real lack of real education, real knowledge about HIV and how it's transmitted, what the dangers are, and the resulting prejudice against our clients has not changed. One little bit, at least in my opinion.
Mm-hmm. Bryn, did you have a thought?
Yeah, I was just going to say, one of the aspects that has always remained constant to me is that there's always, usually, I would say in 95% of the cases, somebody that can step up to be the caregiver in the family if something should happen to the parent. And this is important when I meet with families, that I at least get some names of people who they are considering up front. It may not be what we always focus on, but at least if we ever need to use somebody else in the family, we have an idea of who that's going to be, so it'll prevent some hasty decision making if we confront a situation where a parent is at the end of their life. So I just think it's really a good thing to know that there is family that usually does step up to the plate.
Mm-hmm. Thereby making it less of an emergency situation.
Yes.
Okay. What lessons have you learned in general which have positively impacted the way that you approach your work with families? Adam?
Thank you, Jean. I think it's interesting. I would agree kind of with what people have said already, which is that, yeah, a lot's changed. An enormous amount has changed. People are living longer. and the illness, I think, and certainly a perception of it, it has gone from one that is mortality definite to more of a chronic illness. And I think it has ultimately altered the terrain for working with the clients. What I think hasn't changed is really the stigmatizing part and the unique elements of having HIV, and I think it really does require the things that have really been a positive impact here, and something that I really feel like I've learned by coming to the family centers, that no one discipline, whether it be medicine, law, social work, or anything else for that matter, can fully address the issues of a family that is dealing with AIDS. And it wasn't that long ago at a meeting here, I said that what had occurred to me through my work at the Family Center was that I can say, very honestly, that I've learned something from everyone on staff. And I think that it's important for agencies to at least be open to that possibility. I've certainly learned quite a bit from people here who are not lawyers, and I think it's fundamentally altered in a lot of ways my perception of how this work is best accomplished and how best to serve the client.
Great. Linda, you had some thoughts about that as well.
Yes, thank you, Adam. I really agree with you about the interdisciplinary aspects of this work. When I first started working some years ago with HIV-affected families, I saw plans really fall, as a lawyer, and only a lawyer, I saw plans really fall apart when kids were orphaned, being raised by grandparents or aunts and uncles. Maybe there were teenage children involved that were orphaned, and situations just did not work out. Really, no one was dealing with grief issues, with the HIV issues that were still affecting the family, and then there were all sorts of other issues about raising children unexpectedly, having to take on additional responsibility, and really situations that just really fell apart. That was one of the reasons that FCAN started the Family Options Program, and we find really that the best practices involve legal and social work services working together. I would never ever do work like this again without the assistance of the social workers in our program. It just would not work. And generally when I give a presentation, I ask folks in the audience, how many of you have children? How many of you made plans for your children? How many of those are legal plans? Even if I'm addressing an audience of totally of lawyers, maybe 20% of the folks in the audience have done something about that. To really expect families to do this sort of work without a lot of supports, it just can't be done. So frequently, the more that can be worked out through social work services prior to something getting into court, the better off the case is. So if families can reach agreement about what's the best plan for a child, what's in the child's best interest, that's really what we found to be a best practice issue. Also, for us in terms of best practices, involving families every step of the way in helping to plan the programs that we're doing, and also the legislative issues that we take on, the policy work that we take on, is just really a must. We've never taken on a single issue through FCAN that hasn't been the result of some problems that our families were facing, not only the standby guardianship and standby adoption issues, but worked on changing the law in Illinois so that a potential guardian with a felony background can be considered by the court to be a guardian, where that used to be an outright prohibition, and it still is in most states. At least in Illinois, we've made that stride to create a test that the court can use and they can consider someone to be a potential guardian. We had a lot of cases that involved that as an issue. A lot of families where someone could be a potential guardian maybe didn't even know they had a conviction, or they didn't know what they'd been convicted of was a felony. Grandparents who couldn't raise their own grandchildren because they had something in their past that was 30 years old. Maybe a marijuana possession or sale that at that time was a felony, prevented them from being a guardian, up to more serious matters as well. But we've managed to overcome a lot of that, and so we really are translating direct problems into good policy advocacy, and I think that's something that has been a lesson learned by us through this program.
I don't mean to diminish the importance of planning, because I think it's very important. But I think it's even more important to meet a family where they're at, and that may mean they're not ready to plan when you first work with them. You can get there probably as you work with them, but it's not always on the top of their list of things to do. But I will say when it does get done, and often I'll accompany families to court when they're completing a standby guardianship, and it's obvious that a great weight has been lifted off their shoulders when the actual court makes the decision and the standby guardianship goes through. So it is important to keep it in mind, but I do think it's also important to realize, like, as we've said many times throughout this presentation, that you have to meet the family where they're at, that the situations are really complex usually, and that it takes time to get the goal of planning resolved.
Great, thank you. Let me ask another question of the group. So currently, people with HIV, as we've been discussing, on the whole, have been staying healthier, living longer. HIV/AIDS is now considered by many to be more of a chronic disease. Have better overall health and life expectancies had any influence on your own beliefs and values regarding the importance and relevance of permanency planning work with families? Do you believe that your own personal views are shared by the families that you work with? And if not, how do you handle this? Linda?
Jean, well, I think that it's great that there's better health care that can now lead to longer life expectancy. But I think the notion that this is universally available or is working has really given us sort of a false sense of security. We think that treatments are better now, that people are living longer, and so that HIV has kind of gone away as a problem. And it really hasn't. Many of the families that we see through our work and family options don't have good access to health care. Don't really have good information about managing their health care. Many were diagnosed well into their illness, so they didn't have the opportunity for testing and counseling early, didn't find out that they were infected, maybe were infected as teenagers, didn't have that information, didn't have access to care. Now they're young adults with children and really need to do some planning work for their kids because they're quite ill. We see more and more families in that situation, and as I referenced earlier, more and more families in which grandparents are raising grandchildren that have been orphaned, really due to the same circumstances. I think the characterization of AIDS as being largely over is really at best inaccurate, and that many of the families that we work with may believe that AIDS is now just a chronic illness, but so many have difficulty with medication and adherence, and don't have that living long and living well experience that many of the general public think is going on. We continue to do HIV education with families and are surprised at how much more they want and need to know. And so we build in periodic, very frequent updates. We bring in physicians to talk to folks and just do questions and answers in groups that are supportive of each other, folks that are in the same situation but want more information than they're really getting even from their own physicians. So that's kind of supportive education is really helpful, and we plan to continue that.
Great. How about New York? What's your experience has been, Adam?
I got to go with Linda on this one, except to kind of throw in a comma, which is that, Linda, I think you said that, it's almost a given that clients access health care and that it's all well and good. And of course, we all know that at the end of the day, a lot of our clients experience a ton of problems with those issues. I'd like to just add one point to that, which I think is certainly at times reported to us by our clients, which is that after receiving a diagnosis, all they got was medical services. They weren't really given any strong social services. They weren't given any legal services. I love what Linda said about education. They never report that, or they don't seem to, or anecdotally, they don't seem to report it with any authority. What they got was a pill, and that's valuable and really valuable. But what I thought was what we find interesting about our clients is that at times the other services are really not being thought about at all, and that because clients are living longer, because there is at least a touch of this that has become more chronic rather than fatal, that those services are not really being provided to clients, or they're not accessing those services in the same way that they might automatically, post-diagnosis, be able to access medical services.
Danielle, do you have anything to add?
Yeah, I guess the one thing, and I think Adam alluded to it in our presentation, was that we do frame the topic of permanency planning now as lifetime planning. It's kind of parent planning, and again, if you kind of surveyed your own office about how many parents in the office have made a plan, you might have similar numbers, but it's an important issue not just for people affected by HIV, but for all parents everywhere, to make sure that not only are plans in place, but quality plans, well thought out plans, plans that take into consideration all of the legal, emotional, psychological, and social issues that are wrapped up into parental loss. The other thing that I mentioned earlier was that healthy decision making, starting from an early age, with young people or even with adults, it's really important. I think making healthy decisions about your own life helps you make healthy decisions about your children's lives, even if you don't yet have them. So I would say that that's part of the frame that we're using now.
Excellent. Okay. I want to make sure that we leave enough time for audience questions and answers. So I'm going to ask one last question, and perhaps we can sort of address this briefly. Looking forward for a moment, what scenarios do you foresee that will impact the issue of future care and custody planning down the pike? Can we do anything to prepare ourselves? What kinds of actions are required from whom? What kinds of programmatic legislative advances would you see being implemented to carry us forward? Linda?
Well, one of the things that we're working on right now in Illinois is looking at the issue of termination of parental rights. We work with families who were in cases where there may have been a chemical dependency issue with the family. The parents' rights were terminated after the child was removed from home, the child was placed. We're working with a family right now in that situation where four children were actually adopted by a grandparent who then passed away, and the two other siblings were adopted by an aunt who no longer wants the children. All 6 children are back with their mother now, and so we're going through this process of getting her guardianship of her children, and it's actually already been accomplished. So it's sort of this artificial, she's actually their mother by blood, but we've had to establish a new legal relationship for her, and now we're working on an adoption for this family. So we're going through this a multi-step process involving lots of investigations, lots of court reports, lots of other characters coming into the family's life. There's total agreement in this family in terms of who should really be responsible, and that's the mom. The mom wants to be there. The kids want to be there. The kids are all older. This mom also has a young child that was never removed from her, a child that's now I think about 8 years old. So she's been free from chemical dependency for about 12 years now. So it's a great case for us to begin this work with. But we're really trying to look at ways to amend our laws so that we can restore parental rights without having to go through these artificial ways of doing it legally. So that's one thing that we're working on. We actually have a large coalition now of folks that are working with other types of cases. Our state child welfare department has now gotten involved, our Department of Children and Family Services, and the director of that department is actually participating in this coalition. We're meeting with some policymakers now to look at something that might come into introduction in the next session of our legislature, to try to look again at restoring parental rights in cases where there's not a legal parent who's living who wants to remain as legal custodian for the kids. So but there are so many families in that sort of situation, not just families impacted by HIV, but families where chemical dependency is an issue, and we're trying to help folks get their rights back. I do lots and lots of trainings at residences and treatment centers for men and women that are chemically dependent, and they are really interested, of course, in this topic. Some of them are HIV affected, some are not. So it's something we share in common, our clients share in common with a broader population, and we're bringing in legal service providers from all aspects of the law, of family law, who are interested in helping with this work. Obviously, our adoption attorney bar is going to have an issue with this, and so we'll see how all this works out. It's going to be a big public education issue as well, but public education is a huge piece of this work. Something that we accomplished recently, too, at least on this permanency planning front, was to extend our short-term guardianship statute from 60 days to 1 year. We did that in response to two things: grandparents raising grandchildren, maybe the parents left the child, maybe the parent's either disabled or has left the child with a grandparent, signs what in our state was a 60-day short-term guardianship, and then that gives the short-term guardian the authority to make medical and educational decisions for a period of up to 60 days. Then the parents don't return. So here the grandparents have this child with them, but don't have that authority to make those medical and educational decisions. So we were asked by actually our Chicago task force on grandparents raising grandchildren, the citywide task force here asked us for our help with that. I'm one of the co-authors of the original statute, and we were able to get the law changed to extend it to 1 year, not without a lot of opposition from school districts who were afraid that we'd be moving, that families would move children into better school districts by using this vehicle. The other reason we took this on was that we were working with families where that maybe the parent's unable to make decisions any longer, might be in a hospice or in some sort of a situation where they're not able to make their own decisions or don't wish to make their own decisions, generally not able to make their own decisions. And so they've signed a 60-day short-term guardianship and named the relative or friend of their choice to be a short-term guardian for their child, and then they lose that decision-making capacity. Well, everyone knows that they would have preferred the child to stay with that grandparent or relative or friend, but the legal document is expired, so what do we do? So we at least extended that to a year, and that gives the family more time to work on things and to deal with unexpected developments in terms of the parent's disability and care for the child. So it's a better planning tool. And how do we go about this? It really it takes a lot of advocacy and policy work, but it really takes a lot of advice from families that we're working with on how to do this best and what their problems are, and that's where this work stems from. So those are upcoming challenges and something we just faced. Now we're implementing this new short-term guardianship law. We're actually also seeing folks that are here not in this country who are out of status, and we work with some folks like that through our Family Options program as well, who want to make plans for their child in the event that they're deported. So I just did a training a couple of weeks ago with many legal and social work providers for families that are here that are immigrants and are out of status and are worried about what would happen if they were deported. And so it's just another kind of extension. We've seen that many of the reforms about guardianship and adoption law in many states have changed as a result of this epidemic, and I think that's going to continue in years to come. But we're happy to have been able to do the work we've been able to get done here. So thank you.
Wonderful. Thank you very much. How about you, New York? Do you have anything to add to this, like in 30 seconds, perhaps?
No.
Okay. Okay, that took 5, so all right. That's fine. I'd like to turn it over, though, to the audiences, on-site audiences in Chicago and New York. Let's start first with New York. New York, any questions there in the audience? We've been covering a lot of territory here. I see a hand.
I have a question, which is sort of a general concern about moving forward with this work. Adam had sort of alluded to this, but I feel like everybody's really focused today on how important it is for legal providers and for social work providers to work together. And I feel like we're on a completely different page than the people funding the work that we do, who are finding increasingly that legal services and social services are not of any interest to them in relationship to HIV, and they only want to fund medical services. And going back to the pill, you get your meds, which are important, but that this whole other, supportive piece seems to be dropping out of the whole AIDS funding world. And if people have ideas for how we can address that, because I know in New York we're sort of hitting crisis level with that. So.
The funding piece.
It's a really difficult situation. I feel that there's been I think, Kathy, what you're saying is that there's kind of been a medicalization of services, and I think it's kind of a future barrier, a future challenge that we're all facing. I think we all want to see people get well, and we want to see things change. I think it's going to be a matter, I think especially for us in New York, to kind of keep revisiting and promoting the importance of services, because I don't know if people have read the recent CDC reports, the recent New York Times articles. We referred to this in our outline, but it's not always entirely clear how many people are affected by HIV. And what we know is that depending on what kind of statistical model you use, the numbers can go up and down. Some of this just came out of the conference in Mexico City. It seems like, for a lot of people, that we're going to have to be reminding them that for a lot of our families, for all the reasons that we've talked about today, are going to need a little bit more than a pill, and that they might not be going anywhere anytime fast, unfortunately.
Very good. Chicago, anything to add to that quickly?
No, I think we're experiencing really the same problems with the medicalization of HIV services, and with this sort of, at least the current federal administration really looks at medical treatment as the need that they'd like to fund, and have sort of jettisoned off legal services and social work services. We're trying to work to persuade some of our funders here about the value of the mental health services that social workers provide as a medical service, and we're making a little bit of headway with that, but it's going to be a long road. Thank you.
All right. Continuing challenges. All right. Wendy, you've been quiet here, and I know that you of the expertise that's represented at these two sites, you actually are a person who has perhaps the best expertise, because you're looking at it from all angles. And I wondered, if you've been so very quiet, if we could have the benefit perhaps of some of your last thoughts, reflections, recommendations.
Well, sure, Jean. If I could start it like this, being a person that's impacted by HIV/AIDS, I was thinking about the last question, and I was listening to everybody talking and the legal ramifications that I do not understand. But I was thinking about the funding, and I was saying that it's nice to have the health care like Adam and Linda was talking about. They both posed a good point, but without all the other legal services, the pill is just a pill. You might as well pour water on it, because a lot of us have issues with taking the pill, and a lot of us have issues that we have to have worked out before we take the pill. I am so thankful, as I've told you often, Jane, that I got involved with the Family Options program, because I had all of these ideologies, like earlier I stated, white, black girl. I know that white and black is a color. I know that African American and Caucasian is what you're supposed to say. But I say that according to how people relate, because people don't always relate. I've become this person that I really like. When I was asked about the webinar, I chickened out a few times within myself, but I never told anyone. Sometimes, I was like, oh, well, you just don't have to do it. Just tell them no, and we don't have to do it. But I feel that it's my duty to do it so that people can know and that they can hear that disclosure is the main stigma of why the government can cut our funding. It's because we be so afraid to come out and speak up for ourselves. I was a former drug user, prostitute, alcoholic, lost my children, and my faith had done a wonderful job for me. But I still had problems. And the things that I had to stand up and own up to is when I met Brian. So any opportunity that I get, I go and I tell anyone. AIA, I loved them the very first time I met them because I spent all my life as a young person trying to figure out who makes these rules, who sets these plans, who makes these decisions for our lives. And then I found out that it was people like Adam, Danielle, Linda, Brian, you all that's listening and watching that really care. But we're often told that no one cares. And once I found out that just one somebody cares, it helps me to be concerned and to care about other people, and most of all, and firstly, myself. I have to care about me in order to care about my family. I thank you all so much for even asking me to do the webinar. I am very privileged and I am very proud to have been here today to listen once again to people that really care. Danielle, thank you so much. Thank you very, very much. You also, Adam. And in my closing, I would like to say, you're talking about the youth, but I never heard either one of you talk about how we as parents violate their disclosure and their own personal stigma. We would tell people that, oh, my child is HIV positive, but we won't tell that we are. And it's just so much to deal with. It's a lot to deal with. And Danielle, I was telling you thank you because you were so emotional within your own self as a woman regarding youth, HIV and AIDS. Thank you very much. And bye, Jean.
Wonderfully put, Wendy, as usual. You are just an incredible woman, and I have so much respect for you and what it takes to give these kinds of speeches on the web in front of large audiences, and we continue to learn so much from your experiences and your wisdom, and you are incredibly articulate. We love you too. So I want to thank my impressive group of presenters. They have worked really long and really hard on this webinar. And to you, Linda, Wendy, and Bryn, and you, Adam and Danielle, I have a lot of respect for you all in the field, an incredible respect for what you do, and also I'm so happy to be involved with you as your colleague. I want to thank the Children's Bureau for continuing after all of these years to provide a steady stream of funding for the abandoned infant assistance programs that makes all this work possible. Please don't let these programs go away. We've heard how important this work is. And I want to thank the organizations that have helped us in sponsoring the webinar. the Family and Children's AIDS Network in Chicago, the Survey Center Focus, who loaned us their space, the Family Center in New York City, who does incredible work, and UC Berkeley. Thank you for the technicians. Thank you to the media department. Thank you, audiences, for coming out on site, and thank you, webinar participants. Please, I did get a question about how to find this on the AIA website, so I do want to just mention very briefly that if you go to the website aia.berkeley.edu and you click on the tab for information and resources on the right side of the page, you'll get a pull-down menu. If you click Stand by Guardianship, you will find this, and you will be able to download it. So thank you once again for your time. I'm sorry we've run a few minutes over. Good luck, and we'll be in touch.